So our last presenter before the discussion, Dr. Ruers is going to present the final results of the EORTC intergroup randomized study 40004 CLOCC, evaluating the benefits of RFA, radiofrequency ablation, combined with chemotherapy for unresectable colorectal liver metastases. Dr. Ruers is going to present on behalf of Dr. Punt, Van Coverden, Borrell-Rinkus, Lederman, Poston, Beckstein, Lenz, Mauer, and Nordlinger.
Thank you, Mr. Chairman. Ladies and gentlemen, it's a pleasure for me to present to you the final results of the EORTC intergroup randomized CLAC study evaluating the benefit of radiofrequency ablation combined with systemic therapy in patients with unresectable colorectal liver metastases. Systemic therapy should be considered as a standard of care in patients with unresectable colorectal liver metastases. However, we all know that radiofrequency ablation is increasingly used in these patients. But up to now, we have no prospective randomized studies that are available proving the efficacy of radiofrequency ablation. That was the reason for the EORTC to assess the safety and the efficacy of radiofrequency in combination with systemic therapy in patients with unresectable colorectal liver metastases. And to this end, a randomized study was designed in which these patients were randomized between radiofrequency plus systemic therapy versus systemic therapy alone. And initially, this study was designed as a randomized phase 3 study. However, during the course of the study, an increasing number of surgeons and investigators became convinced about the use of radiofrequency. So it became increasingly more difficult to include more and more patients. So we had to take the study down to a randomized phase 2 study. And the primary objective in this randomized phase 2 study is to demonstrate a 30-month overall survival being more than 38% in the radiofrequency arm. The secondary objectives were progression-free survival, overall survival, safety, and quality of life. To comply with the primary objectives, we needed 152 patients to a group of 76 patients. And the study protocol started in April 2002 and ended in June 2007, when the study was closed somewhat earlier because of a decline in accrual. The main eligibility criteria of the study were unresectable liver metastasis and no possibility to radically resect all tumor lesions. The number of metastatic lesions should be lower than 10, and the maximum diameter of the lesions to be treated by radiofrequency should be smaller than 4 centimeters. There should be no extrahepatic disease, and prior systemic therapy was allowed as long as there was stable disease. In arm 1, in the radiofrequency arm, these patients were treated by radiofrequency plus systemic therapy for 6 months, and radiofrequency was performed either during laparotomy, laparoscopy, or percutaneously. In the control arm, only systemic chemotherapy was given for 6 months. And systemic chemotherapy consisted of FOLFOX4 from 2002 to 2005, and FOLFOX4 plus bevacizumab from 2006 and 2007. And after 6 months of treatment, treatment was to further discretion of the physician. Follow-up of the study consisted of every 3 months a CEA, a CT abdomen, and a chest X-ray. Patient characteristics were equally distributed between both arms. Far most patients had multiple lesions in both lobes of the liver, and the median number of lesions were 4 and 5 in both groups. This slide shows you the further treatment information. 60 patients were assigned to the radiofrequency plus chemotherapy arm. 72 received FOLFOX, 13% received FOLFOX plus bevacizumab, and 6 patients were treated by radiofrequency only, because these patients had a complicated postoperative course. 3 patients in this group were not treated at all, because they refused or they had extrahepatic disease and shouldn't have been included. In the chemotherapy arm, 78% received FOLFOX, 22 FOLFOX plus bevacizumab, and at the end 7 patients were resected in this group. Because in the study it was allowed, when chemotherapy made unresectable disease resectable, you could go for resection, and at the end 7 patients were resected in this group, being 12%. Radiofrequency was performed either as only treatment in 52% of the cases or in combination with resection in 47% of the cases. The radiofrequency was mainly performed during laparotomy, and the mean stay in hospital after procedure was 4.8 days. Postoperative complications and toxicity. 3 patients got a cardiac complication, being a slight cardiac insufficiency after the operation. 2 patients got a hemorrhage, and 6 patients got either a superficial wound infection or an abscess. And 1 patient died of a sepsis. The toxicity of chemotherapy was comparable in both arms, with a slightly higher cardiac toxicity in the radiofrequency arm. The primary objective of the study was a 30 months overall survival. And in the radiofrequency arm, 63% survived at 30 months. And as you can see, the primary objective was to obtain a survival of over 38%. The primary aim of the study was reached. However, also in the control arm, survival was higher than 38%. And we have to realize that we scaled down the study to a randomized phase 2 study, meaning that this study was not powered to find a significant difference in overall survival at 30 months after inclusion. And indeed, the overall survival curves shows a completely parallel course of the curves during the first 3 years. However, after 3 years, the curves are clearly separating. In the radiofrequency arm, at 4.4 years of median follow-up, 29 patients were still alive compared to 20 patients in the chemotherapy arm. And patients who died almost exclusively died of progressive disease. The secondary objective of the study was progression-free survival. And radiofrequency plus chemotherapy resulted in a median progression-free survival of 16.8 months, compared to the chemotherapy arm, where median overall progression-free survival was 9.9 months. And this difference was highly significant, with a p-value of 0.24 and a hazard ratio of 0.63, as you can see in the Kaplan-Meier curves. The first site of progression in both arms were mainly the liver, being 64% in the radiofrequency arm and 84% in the chemotherapy arm. What is important to note in this slide actually is the local recurrence rate at where the area where the tumor was treated was low. Only 5 patients received or got a local recurrence, being 11% of all the patients treated by radiofrequency who got a recurrence. The other second endpoint was quality of life, and this was measured by the EOTC C30 scale on global health status. On the left side of the slide you see the global health status in the radiofrequency arm, and on the right the chemotherapy arm. And you see that there is a slight drop in quality of life only early in the course of the follow-up, and this is just the period around the radiofrequency procedure. However, within 6 weeks after the radiofrequency procedure and after operation, health-related quality of life were completely back to basic values. So, what are the conclusions of this study? First of all, the primary objectives of this randomized phase 2 study, being a 30 months overall surviving higher than 38%, is reached. But also in a systemic therapy alone arm, 30 months overall survival was higher than 38%. But we have to realize that we can't find a significant difference, or at least that it is very difficult in this phase 2 randomized study, because figures are too low and patient numbers are too low. However, the progression-free survival in the radiofrequency plus systemic therapy arm is significantly improved compared to the systemic therapy alone arm, with an extension of almost 7 months. And health-related quality of life showed only a very small dip, which was only transient after the radiofrequency procedure. I have to thank all the patient and participating centers and all the institutions mentioned on this slide. Thank you very much for your attention.
Thank you, Dr. Ruers. That was an excellent presentation. If I again may start with the first questions. I just noticed in your demographics slide that the chemotherapy arm seemed to contain patients with higher tumor burden in the liver, and more of them had synchronous liver metastases, which are both adverse prognostic factors. In your opinion, could that have actually improved the outcome in the radiofrequency arm, tilted the outcome to more positive in the RFA arm versus the chemotherapy only?
No, this difference was not significant. It was only a minor difference, and of course the groups are quite small. You can have these incidental differences, but I think it was only incidental.
Okay.
So you can't explain this huge difference in 7 months by just only just this small difference, which was not statistically significant.
Thank you. So we'll start with podium number 1.
Hi, John Berkowitz from NCI. I was wondering, in terms of, could you tell us, did all the patients have their primary resected, and if so, was the RFA done at the same time as the primary resection?
Primary resection was all patients had a primary resected, and the procedures of radiofrequency were all done afterwards, so not together with the resection of the primary tumor.
Okay, number 2.
Vogel, New York. Thank you for doing a very difficult study and reporting it so well. I have a question as a non-surgeon about the technical success of the RFA. What % of the patients assigned to RFA did the surgeon feel that he'd gotten all the lesions with a negative margin? How technically successful was the procedure? Obviously, if they chose poor patients, tried to do 15 lesions and got out 8, it wouldn't do the patient much good.
Now, the basic principle that the surgeon decided only to include patients if he could treat all the lesions. Right, so that's the basic principle. So no debulking, it's only you should be sure that you should be able to treat all lesions. And actually in the whole study we treated 170 lesions with radiofrequency, and we had a local recurrence of 11, meaning 7%. So we were very successful actually in getting this done, getting this job done very well. And I mean, one of the reasons is probably that we did this during open surgery quite often, and this makes it a lot easier than for percutaneous use.
I guess, let me rephrase the question. Were there any patients in whom the surgeon knew when he closed the abdomen that he'd left cancer because he couldn't ablate it?
No, there were no patients.
Okay, number 3.
Chris Emanuelides from Greece. Again, I would like to thank you for a very difficult, tackling a very difficult issue, clinical issue. I noticed that most of your patients had invasive procedure for the ablation, and yet you had a fair number of patients with metachronous metastasis. And the question is, could they have gone to percutaneous ablation, or what are your feelings about that? Did I interpret your data right?
That's correct. And one of the reasons, I mean, we designed this study a couple of years ago, and at that stage we were quite confident about the technique when you do it during open surgery. And at that time, results of percutaneous radiofrequency were certainly worse than during open surgery. So that's the reason why in most of the centers, we decided to do open.
Okay, last question, number 4. That would be the last question.
Falcone from Italy. I noticed that in the radiofrequency arm, 47% of the patients received also surgery. So the question is, which do you think was the impact of surgery in this arm? Is the radiofrequency effect or a surgery effect?
I don't know whether you should view it this way. The way actually you should look at these data is that there is a group of patients where you can't clear the liver by resection alone. And up to now, these patients are treated by chemotherapy. And this study shows that when you introduce radiofrequency, either alone or in combination with surgery, results are better than chemotherapy alone. And whether this is the combination of resection with radiofrequency or radiofrequency alone, that's probably not actually absolutely the issue. It's just that you go ahead quite aggressively with these patients and try to clear them all of all liver lesions.
Yeah, so it's an effect of the combination of the two. And how many patients receive surgery in the no radiofrequency arm? How many patients? Was 47% versus?
52 only received radiofrequency and 47% received radiofrequency plus surgery.
Thank you, Dr. Ruers. That was an excellent presentation. Thank you again.